Hello, my name is Patty Eaton, and I'm currently a Pediatric Emergency Medicine Fellow at Arnold Palmer Hospital for Children. This is an educational tool created with the assistance of Dr. Lauren Zins, a Pediatric Emergency Medicine attending physician at the Children's Hospital, and Dr. Paul Mullen, a Pediatric Emergency Medicine attending physician at the Children's Hospital of the King's Daughters in Norfolk, Virginia. Existing literature has established that debriefing is a low-cost, time-efficient, and effective method to improve team performance in resuscitations in the emergency department. However, despite this growing body of evidence, the majority of resuscitations in EDs still are not followed by a debriefing session. There are multiple tools available in the literature for how to conduct a debriefing, such as the Plus Delta model, Discern, Reflect, but there is lack of an existing distributable training tool other than an abundance of published articles on the topic. This realization has served as a motivation behind our project. This educational tool is intended to provide you with the knowledge, tools, and confidence necessary to improve upon the quality and frequency of debriefings currently being conducted by physicians in the emergency department setting. Here is an outline of what we plan to address in this tool. First, an overall introduction to establish some definitions and general principles. Next, we will review some of the existing literature on debriefing that has supported its use thus far. Most importantly, we will discuss and demonstrate how to actually conduct a debriefing in your ED. We will then summarize some key information and finally supply a list of references that we use to create this tool and for your further reading if you're interested. The resuscitation of a critically ill patient in the emergency department often occurs amidst an otherwise busy day and a department full of multiple other clinical duties. Thus, following the resuscitation, the staff is usually eager to return to the patients they have kept waiting. This frequently results in miscommunication and confusion regarding the details of the resuscitation, unsettled emotional distress of staff, and potentially the open opportunity to repeat pitfalls or imperfections in the resuscitation care. For these purposes, a resuscitation can be defined as the emergent management of a critically ill patient that may or may not result in death. A debriefing can be defined as a discussion after a resuscitation involving two or more members of the resuscitation team. The concept and practice of debriefing originated in the military. It has expanded to various other professional organizations and has multiple goals, with the overall intentions of improving future performance in patient care through joint reflection and communication. Let's review some of the existing literature on debriefing. Debriefing after resuscitation is currently recommended by the American Heart Association, the Institute for Healthcare Improvement, the American Academy of Pediatrics, and the European Resuscitation Council to improve future performance in medical care. The AHA consensus statement in 2013 stresses the importance of establishing a process for post-event debriefing that best fits the culture of that particular institution, the resources, and the time that's available. They further recommend to define who will lead the debriefing, preferably someone trained as a facilitator, and when it will occur. They support that debriefing is used to identify best practices unique to the institution to optimize performance as well as to address emotional responses related to the specific event. A quantitative meta-analysis performed in 2013 revealed improved effectiveness and team performance by 25%. After clinical cardiopulmonary resuscitation events, debriefing programs have improved technical CPR performance, rate of return of spontaneous circulation, survival to discharge, as well as neurologic outcomes. Several studies have noted further benefits of identification of errors, promoting team morale, supporting staff emotional well-being, as well as improving overall staff satisfaction in the work environment. Post-event debriefing is known to be an effective educational strategy for students, residents, and fellows. Mullen et al. Described how it demonstrates Kolb's theory of experiential learning, as well as addresses all 6 of the ACGME core competencies. Debriefing after clinical events allows for the immediate feedback that we know is so beneficial in adult learners. It promotes enhanced interpersonal skills and communication across disciplines within the clinical team, and emphasizes the importance of effective teamwork and professionalism. It provides an opportunity to review and discuss the medical knowledge pertaining to that event and the team's clinical performance and care. Debriefing capitalizes on practice-based learning by using the clinical encounter as a context for identifying strengths and weaknesses, promoting performance improvement, and assimilating evidence into practice. It can address competency and systems-based practice as well by enhancing the awareness of how clinical actions are influenced by the inherent characteristics of the care environment and the overall healthcare system. It could also fulfill the ACGME goal of acquiring 360-degree feedback. Nevertheless, despite the existing and growing evidence of the benefits of debriefing, a recent national survey of pediatric emergency medicine fellows published in Pediatric Emergency Care in 2014 revealed that debriefings are following only an estimated less than half of ED resuscitations. Fellows report a lack of formal training, lack of structured format, and a limited comfort level in conducting debriefings. In addition, almost a third had never participated in a post-resuscitation debriefing session themselves, and almost half reported feeling neutral to very uncomfortable leading a debriefing session. However, an impressive 92% expressed an interest in learning more. These findings were supported by a similar study published by Sandu et al., who surveyed 80 nurses and attending physicians across Canada and found debriefings are occurring less than a quarter of the time, and that 63% of participants had no training in debriefing. This data served as the motivation for our present project. Now let's discuss how we recommend that you conduct a debriefing. At the end of the resuscitation, designate a place and time to meet, such as in 20 minutes, we will meet briefly back in the trauma bay for a debriefing. Invite all who were present to attend. The session should take place as soon as possible after the event. This allows for more team members to be present, as in an ED, your team is often unique on each given day. Also, improved participant recall of events and early addressing of teamwork and emotional settling. The goal duration for the total session should be less than 10 minutes, although this could vary. This is especially optimal in the ED setting, as the team members often have other clinical duties to attend to. Dr. Lauren Zins has developed this innovative mnemonic tool to serve as a guidance in conducting a debriefing session. R stands for review the event. You're going to start with a one-line case summary, such as 9-year-old with asthma presented in severe respiratory distress. E stands for encourage team participation. Create an environment without judgment so that all are encouraged to openly discuss. F, take some time to provide specific, constructive feedback on the exact details of the resuscitation. L, listen to each other. Be sure everyone is creating a respectful environment so that all are participating. E, emphasize key points. Take some time for each participant to go around and provide their name, role, and one thing that they took from the experience. C, be sure to communicate in a shared language so that all present can understand, whether it's a tech, nurse, physician, social worker, or child life specialist. Most importantly, talk about transforming the future and what you can do better next time. Plus Delta is a general method of debriefing that provides a simple, organized structure posing 3 basic questions to the team. These are the actual steps and structure that we recommend. First, what happened? A brief synopsis or one line of the case. Again, 9-year-old with asthma presented in severe respiratory distress requiring endotracheal intubation and ICU admission. Next, you talk about what went well. This is your plus component, such as the team leader was clear and audible, or we worked efficiently with quick transfer to the ICU. Finally, what can be changed for the future? This is your delta component, such as we need to improve access to a piece of required equipment, maybe add a medication to our Pyxis, or clarify CPR techniques. Here is an example of a form you may use as you conduct a debriefing session. Mullen et al. Published a different study using a similar tool, which reported debriefing rates of 88% with use of the form, compared to 6 to 31% of previous studies without a tool. This was possibly related to the accessibility and/or utility of a structured format. 64% of these sessions lasted less than 10 minutes, which supports the feasibility of using the form in the ED setting. Standardizing the format of your session allows your team members to anticipate the process, helps to align department goals, and to keep focus in a potentially emotionally charged situation while maintaining time efficiency. This form is for peer use only. It is not intended to become part of the patient record and is not litigation or case review purposes. Here's a demonstration of a debriefing session created by Dr. Lauren Zins and her team at CHOP.
That was a really difficult case, and whenever we have situations like this, they're really tough for all of us, and they affect all of us in different ways. The point of this is not a blaming session. It's to talk as a group about things that we did well, and talk as a group about things we can improve on, and also give an opportunity, especially in a case like this where a patient has died, just to talk about any emotions that we may have as a group. So what we'll do is we'll first just go around the room and say our name and what our role was in the resuscitation, and then I'll give a really quick one-line summary of the case, and then we'll open it up to the group. So I'm Dan Corwin. I was the attending who was running the resuscitation.
I'm Jackie Rosen. I'm one of the child life specialists in the resuscitation.
Amelia Hayes. I was also one of the child life specialists there.
Mark Sheedy, respiratory.
Denise Hopkins, I'm a second respiratory therapist through RAD.
Trish Janoff, charge nurse. Lauren Zins, also an attending in the resuscitation.
All right, so this was a 4-month-old who came in without notification, who had been found down at home. Nothing was done in the field. We quickly got access and intubated, and after 3 rounds of epi and continued CPR, we were not able to get pulses back, and eventually declared dead. So at this point, I'd like to open it up to anyone who has anything to say that they thought went well during a resuscitation.
I thought there was really good closed-loop communication among the team members.
I thought the CPR went really well. The compressions were great. We could see them, the heart rate on the monitor to show the compressions were really done well. And we also had a line set up for so we could relieve whoever's doing compressions every 2 minutes.
Yeah, and I think part of that was Lauren stepping in to be CPR coach. I think it's really tough for the leader to try to focus on the minutia of CPR and everything else going on. So taking that off my shoulders was really, really helpful. So I appreciated having Lauren there to do that.
I also thought the communication was really good, knowing who the team leader was and everybody knowing their roles. The nurse and respiratory and good coaching, closed loop communication.
Yeah, everybody was really focused on their job, and as a team, it just worked out real well, and I'm really happy that we all worked together, even though it's a sad situation.
I think even though it's really hard to hear a mother being so upset, it was really great that she was able to be there and see everything that we were doing for her child, and there was always somebody coming back from the bed and updating mom about what was going on. So it was good that we were able to keep her updated.
Other things people thought went well.
I thought initially the CPR before intubation, having the end total in line was great, so we can see if there was any return to circulation. But once the patient was intubated, I thought our adrenaline was going and we were bagging a little bit fast.
Mm-hmm.
Good thing for the CPR coach told us to tell
Yeah,
us 6 to 8 every 6 to 8 seconds, so that was helpful. Thank you.
I also think, Dan, you did a great job as leader. You were commanding the room and giving very clear orders to the team members so they knew exactly their tasks.
Okay, how about things that we can improve on?
I think most of our resuscitations are really difficult because a lot of people come in to help, and it's really hard to get them to leave when we have enough staff in the room. And that's something we struggle with every resuscitation.
Definitely.
I was going to say another thing, unfortunately, because the page went out a little later than we were hoping for. Social work came a little later and wasn't there initially to support the family. And child life wasn't there from the start. And there were siblings present that needed some support around what was happening.
Yeah, and that's on us. The second we walk into the bay, we need to hit the tweeter, and we need to make that just rote muscle memory. Because you look around, you think you have everyone you need, because a lot of people were gathered around, and all the nurses were there. I mean, 2 respiratory therapists there, and a radiology tech was there. So it was like, we have everyone there. What do we need? But that's why. And then we have an unsupported mother who no one's paying attention to as she's watching her infant getting CPR. So definitely, that's a great point.
Yeah, you guys are helpful, because when the mom's crying and everything, it's really hard on us, especially when they're saying, save my baby, please do everything for my baby. It's hard. So you guys are good to keep them, so we appreciate you guys coming in.
Thank you.
So you got access really quickly. Sometimes that doesn't happen.
Definitely.
Yeah, no, I think it's great. This is a situation where we weren't prepared. I think if we know a CIS is coming in, then we have an IO ready, we have fluids ready, we have everything lined up, and even though we didn't have any pre-warning, I don't remember who it even was, but quickly grabbed the IO and it was sitting right there. So Lauren could pop it in 3 seconds after we get to bed, which is great.
We recognize that these events are very emotionally charged, and that's why these debriefings are so important. And so we thank you all for participating and for contributing to this significant debriefing. And certainly we're available and around if anyone has additional questions or concerns going forward.
Yeah, I would definitely echo that. That this is sometimes a hard setting to discuss, especially emotional aspects. Or they may hit you 5 minutes from now or 3 hours from now, but Lauren and I are available. Trish is our charge nurse.
And I
available.
would collaborate with you as the attending and me as the charge nurse to review who was in the trauma room and just assess their emotional state, because some people can go right out and take care of patients again, and some people need to be relieved for 20 or 30 minutes to kind of have a drink, process what happened, and return back to work. And it's really difficult in the ED, especially if you have like 20, 30 people in the waiting room and other critical patients. So we'll work together on that.
Yeah, no, I think this is...
As part of the team member, I'd say I really appreciate you asking everybody's opinion once you, as a team, decided that we were going to call it. And I thought that was really awesome, because we are a team now.
Yeah, it is
Definitely
nice.
a team.
I agree with that. Does anybody have any other thoughts? Anybody have any recommendations? So that's awesome. I like being...
Yeah. No, I mean, as emotionally draining as these situations are, I think they're always heartwarming in the sense that it really shows our true colors and how phenomenally we work as a team. And it makes me really proud to work with everyone here.
Yeah.
Thank you, everyone.
Thank you.
In summary, there are multiple benefits to debriefing after resuscitations in the emergency department, ranging from supporting emotional stress of your staff to promoting teamwork, as well as improving the quality of patient care. It provides a quick, open communication and discussion of a process of patient care that is often busy, high stress, and complex. It allows your staff to better understand and appreciate your thought process during the resuscitation and to close gaps in communication or understanding that may exist. We recommend the simple plus delta technique in 3 basic steps: what happened, what went well, and what can we do better next time. This is intended to be a quick exercise, taking on average less than 10 minutes of time away from your other ED responsibilities. And you may find this a relevant and useful tool in a variety of clinical scenarios, other than the most medically acute or coding patients, such as a very emotional patient encounter, like a new cancer diagnosis or child abuse case, or an aggressive and violent patient. Anything that stresses or strains your medical team and would benefit from a brief discussion. We wish you good luck and much success in your future debriefing sessions and hope that we have succeeded in providing you with the knowledge, tools, and motivation to implement this into your future practice. Thank you.